Oh, we got 14 attendees. Hello, everyone.
Hi, ladies. Thank you guys for joining.
We have 14 out of 26 people who are on now. So we're going to wait just a minute for everyone to join us. But for those of you who haven't seen me before, I'm Sunshine. I know I see a lot of my wonderful surrogates that I've screened in our waiting area. I wish we could see your faces because that's what
I know, that would make it easier.
But I'm Sunshine, and we have Natalie here and Casey, and we can all introduce ourselves in a minute. But while we're waiting for everyone to join on, I just wanted to make sure you guys can see on the side of the screen, you should see a chat. Right now, I have the chat private, so only Natalie, Casey, and I can see everyone. So I'm going to make that public for a second so you guys can go ahead and introduce yourselves. And then I was thinking, and maybe I can do a poll for this, see how you guys feel. If you guys felt confident asking your questions, it's really safe. Like every single woman that's joined this webinar is awesome and wonderful. So you should feel completely confident asking all of your questions and not feel insecure about it. But feel free to go ahead and introduce yourself in the chat. My husband, Kyle, is here too, lurking. So he's just going to help us with tech support if we need it. He's in the chat, and I can let him delete his little message. But don't be afraid of Kyle. He's very nice too. Oh, he's leaving. He's all, sorry, bye. We also have here next to the chat, there's a poll. There are 2 polls on here. If you guys can go ahead and answer. The first question is asking how comfortable you are, how confident with the IVF process on a scale of 1 to 5. I might go ahead and re-ask this question toward the end and see if anybody's confidence level rises. Hopefully it will. And also, I'm curious how many of you plan to do your own injections versus having your spouse or partner or neighbor or cat do them for you. And then next to the polls, there's a handout. I know I sent an email out to everyone, and I sent it out late last night. So you probably got an email that said, "Hey, Sunshine," because I was talking to myself. Sent you an email with the attachment, but it's here too, in case you haven't already downloaded it. Feel free to download it there. It's just an outline of the things that Natalie's going to discuss, because she's going to give us a lot of really helpful information. And of course, you're not going to remember it. So it's all there for you to take notes on and keep track of. So I'm going to let Casey go ahead and introduce herself. And then we'll let Natalie introduce herself. And then Casey and I will turn our cameras off so we can just let Natalie do her thing. Okay.
Yay.
Casey?
Hi, ladies. I'm so glad that you're joining. We are so excited to be doing this. And I honestly think this is so beneficial for you lovely ladies who are going to be embarking on your IVF process here very shortly. You are in very good hands. Natalie is amazing, a dear friend, so knowledgeable, and has been in this industry for a long time. So I'm excited for her to share what for you guys to anticipate through this process. And I can't wait to hear all of your guys' feedback afterwards to see what you guys think. So I'm Casey for the people that do know me, and 2-time experienced surrogate, and really excited to be a part of this with you ladies.
Oh, I'm so excited to see everyone in the chat too. So cool. We have a couple people from Utah. We have Coral from New Jersey. We've got people in Vegas, New Mexico, California, Tennessee. Oh, lots of Texas girls.
Yes, we love the Texas girl.
Awesome.
Yay.
Okay, so I think we have 17 out of our 26 registered attendees. If other people hop on in the middle, that's okay. If they're late, they'll get a recording, so they won't miss anything. And we'll just go ahead and let Natalie take over. Tell us who you are, Natalie.
All right. Well, hello, all you lovely ladies. It's nice to see so many people from different states, and welcome. And I'm so excited to be able to share what I've learned throughout my journey. Again, my name is Natalie. I'm here in SoCal. I've worked within many different IVF clinics throughout Southern California over a span of, gosh, going on 17 years. I started as a medical assistant and worked my way up from the back office and did surgical technician to phlebotomist, and then eventually went into case management and started working with patients in third party, which is donor surrogates. I found a love for that and have continued ever since. Throughout my journey, at some point, I did become really close with one of my patients who was looking for a surrogate. So about close to 10 years now, I offered and decided to become their surrogate. For me, that was a great journey because I was able to relate all the medications I've been working on with patients and experience it myself, experience the journey, work with my intended parents on so many levels. And so I feel like that really connected me with my patients moving forward in my career. And so with having surrogacy under my belt, I went on to do third party for a long time. And then at some point with managing cases and working on medication instructions and seeing all of the issues or concerns that a lot of patients had, last year I thought it would be interesting to start my own injection service. So of October of last year, or 2019 actually, I decided to start an injection in-home service. And so I started offering my care after hours, because a lot of times nurses are only available during business hours. And then after hours, sometimes they have on-call services where you can call an on-call nurse or physician. Sometimes they're not available. So it's nice to have a nurse that you can call and schedule appointments with to help you, whether it's getting past that first hump of that first injection, just so you have somebody to ask questions to, or dealing with the whole cycle and ensuring that your cycle goes 100%. So that's what I do. I love working with my patients. I love fertility. It holds a special place in my heart. And I know these lovely ladies from my journey as well. So that's a little background of me. And I'm really excited to kind of share my knowledge with all of you as you start your journeys. So we wanted to go through a little bit of the process from start to finish of just what to expect in the clinic once you've matched with your intended parents. And so what we normally start with is your initial medical screening. So once you've matched with your intended parents, the first thing they want to do is send you to the IVF clinic so that you can have your initial full physical, full uterine cavity evaluation, and then blood work. So I wanted to go over those details first. The physical is speaks for itself. It's just the doctor making sure your heart and lungs sound good. It's just ensuring that there's no underlying conditions that they might see. Blood testing is all checking your hormone levels, TSH, which is your thyroid, prolactin levels, making sure your hormones are not at an imbalance, and then also checking your infectious disease, so hepatitis, Hep C, HIV, GC, which is gonorrhea, and chlamydia. All of those have to check out. If you do have a partner, we also check their blood test to make sure that they're good and all is negative before moving forward. And then the third part to all of that is the uterine cavity evaluation. So the doctors want to ensure that your uterine cavity doesn't have anything impeding on a pregnancy, which includes fibroids or polyps, making sure that the cavity is completely clear. So what that entails is the doctor will, almost like a pap smear, they will use a speculum, and then they are introducing saline into the uterine cavity. And so what that looks like on ultrasound is it blows up kind of sideways your uterine cavity with fluid so that they can see the outer lining of your uterine cavity. If anything is found, that doesn't mean that you are X'd out completely as a candidate for a surrogate. That might mean that you need a hysteroscopy. You just have to have whatever polyp or fibroid they possibly see removed. And that's a super easy procedure too. Hysteroscopy is done under anesthesia. So It is a little more invasive, but it's definitely planned, with your next period. The doctors will arrange that. It all sounds like a lot, but that's just potential, something that can come up if it's needed. So once you have all of your screenings done and you're cleared medically as a surrogate, you'll go on through the process with legals and all that stuff, and the girls, I'm sure, will go over that with you. And you're just a step closer to your cycle for embryo transfer. So the next thing is planning your embryo transfer, or what they might call an FET cycle. That's frozen embryo transfer. There's a lot of things with that. A lot of times the doctors will plan it based on your period. So they want to keep track of your menstrual cycle. So they will have you'll hear a lot, call us the next day one of your period. They want you to call in so that they can start keeping track. Some doctors may put you on birth control pills. So birth control pills, I know that sounds a little ironic. We're trying to get pregnant, we're trying to make a baby. Why am I on birth control? It actually helps so that they can control your period. And with controlling your period, we can put you into a cycle so that you're then ready to start medications based on the timeline that they might have for you, for the intended parents, or for the clinic. So then once we've determined dates and your period and whether you're going to be on birth control or not, they will issue you a calendar and they will start ordering your medications. So a calendar can look different in many ways from one clinic to the next. Sometimes they'll give you a grid-like calendar that is mentioned by day and just like your typical wall calendar. And it'll have on each day which medications you take, when you're expected to come in for appointments. And so once those dates are locked in, then they'll schedule your appointments as well. All of your medications will be most often shipped to you directly. Some clinics will have them shipped to the clinic, and then you'll pick those up at your first appointment. And these are all usually sent from a compounding or specialty pharmacy. It's not your typical CVS or Rite Aid, because these are special compounded or fertility medications. They come from specific pharmacies. Some clinics may use outside monitoring. So once they issue you a calendar, if you're coming from out of state to your clinic for the actual transfer, they will locate a local IVF clinic, OBGYN office, sometimes an imaging center for the ultrasound, and then you'll go to a lab for lab draw. But the outside monitoring is just for a clinic closer to you so that you can have the testing done. Those results are then sent to your fertility doctor, and then they review those throughout your cycle to ensure that everything's going well. So that may be something that you may help your coordinator locate, or they may have someone in mind based on where geographically you're located. So keep that in mind, that you may need more appointments throughout the cycle, but that doesn't necessarily mean if you're flying to your clinic that you have to fly in every appointment. Okay. Organizing your medications in time. So as I mentioned, you're going to be getting your medications, especially if you're out of state, they're going to ship them to you. Everything's kind of packaged and organized how it needs to be stored. Some medications may require refrigeration, and it'll all be packaged the way it needs to be stored. So if there's medication that needs to be refrigerated, those will be put on ice packs and shipped to you. So you'll just kind of make sure when you get everything that you open things right away. You don't let them sit for too long, just to make sure that your medications are being stored properly. If anything's questionable in your package, call the pharmacy. The pharmacy number is on your prescription labels. So just give the pharmacy a call, and it's just a quick question to them of asking, I got this medication, I'm not sure if I need to store it in the refrigerator, can you confirm? And most of the pharmacies are really helpful. The pharmacists are really nice. So that shouldn't be a problem. And also managing your time. So once you get your calendar with dates, if there's any discrepancies, if there's any timelines that don't look, that interfere with your schedule, try to be as flexible as possible because it's really hard with the IVF process to kind of rearrange. Once we know the timeline from your period to when you start meds to when your transfer is, it's a little hard to kind of manage or kind of shift things around. So if you have any questions with the timeline, make sure you're always in communication with your case manager or your nurse coordinator at the clinic. That's usually who will help you to schedule those appointments. And they'll let you know what appointments you can be flexible with and others that we can't move. So they'll be really helpful with that. So then once you get your medications and you've organized them, you stored them properly, moving forward as you have your calendar, there's a couple of helpful tips as to how to organize them. I always tell patients you're going to be really overwhelmed when the box of medications come in, and you're going to see needles, you're going to see syringes, you're going to see a sharps container, and everything's going to be labeled, but it's going to be a big box. So take a breath and organize everything, take everything out, look at all the labels, kind of match everything to what you think based on what your nurse or coordinator has gone over with you on. If there's anything questionable, you can always call your nurse coordinator or the pharmacist. Things you can do to organize, I've had patients use the closet shoe organizers that hang on your back door. They've labeled those really nicely with each day of their medications so that they don't miss a dose. They've set alarms. They've used plastic bins to kind of organize each medication separately from one another so they don't get confused with needles. So whatever makes you less frantic about having things. I know everybody has their own way of organizing, and there's no right or wrong way, just whatever makes it easier for you to kind of follow along. Administering your medications. So you'll get time with your nurse at the clinic to kind of go over each medication. There's lots of different forms of medication. There are oral injections, there are vaginal suppositories, there are transdermal patches that are put on the skin. You have your subcutaneous injections, which are just under the skin surface. So they're the little, almost like a diabetic needle. And then you have your intramuscular injection, which is the big one, which I'm sure most of you have heard of because that's the one that's talked about the most. So that's usually gone on the backside. We're going to go over that one in detail right now. And so depending on what protocols your doctor at that IVF center uses, you can use various number of these, or several, or maybe one or two. So let's go over some of the typical medications and the forms. So at the beginning of your cycle, you're going to start on, some doctors will start you on Lupron, which is a small sub-Q injection, or they may start you right into an estradiol injection or suppository. So there's different forms of that too. So one of the first medications introduced could be a Lupron injection. What Lupron does is it suppresses the ovaries and it keeps everything quiet so that we can build your lining while your ovaries, so it kind of keeps your ovaries from growing any large follicles while your lining builds with the estradiol medication. So some doctors you may see use Lupron, others kind of pass that completely and just start you on estradiol. There's no right or wrong. I know we like to compare from one surrogate to the next who's taking what medications. All protocols work just as well. It's just what the doctors prefer at their clinic. So you may need a sub-Q injection, which is given in the belly, just like a diabetic insulin injection. And so you're using this small little needle, and they'll give you your dosing on your calendars. They'll give you full disclosure of what your dose should be every night. And you always want to make sure you have all your tools. So in the medication order they send you, they'll send you tons of alcohol swabs and gauze pads. So the alcohol swabs are important. You always want to alcohol the skin before your injection. And you never want to use the needle more than once. So they'll give you a sharps container. So one-time use needles, they always go in the sharps container. Okay. So I see someone's going to be taking Lupron for all 3 of her cycle, or had to take Sunshine. Sorry, you had to take Lupron. So I would say this is probably the easiest one. It's a good way to get your feet wet with the experience of an injection. It sounds scarier than it is. You'll usually use a multi-dose vial, and you're taking your injection out of a multi-dose. So when you're taking it out of the vial, it looks probably similar to this or a little smaller. You're always alcoholing the top of the vial, and you're always going to use a new needle. They'll tell you based on what your dose is, what you're going to be drawing your medication up to. And then once your dose is measured, needle goes all the way in. So if I'm using this little fun doodad, this is fake skin, but your needle always goes all the way in. So it's always a quick jab. Patients always want to take their time and slowly inject. It's almost like a dartboard. You know, it sounds bad, but the faster you go, the easier it is. You inject the medication. As you're releasing the needle, you're going to apply pressure with a gauze pad and apply pressure to the skin for less than a minute, but that just minimizes any potential bruising that you might have. Not all patients will be on sub-Q injections, and not all patients will be using Lupron, but that is one common used medication that patients will see firsthand. And of course, write down any questions that you might have. If I skip through something too fast, let me know. And I'm happy to answer questions at the very end. So another medication that patients might be using, estradiol. So estradiol is introduced at the start of your cycle at the beginning, and that's to help build your lining. So estradiol is a hormone that helps the uterine cavity, helps with the endometrial lining. So that's important at the beginning of your cycle because we want the thickness of the lining to grow before your transfer. The thickness of the lining is what helps to kind of make a nice comfy bed for the embryo. So that's a really important medication. Some doctors use suppositories, some will use a patch, and some will use an injection. Our doctors here use suppositories and oral medications, estrace. And sometimes if you have a low level, they can try multiple forms. If you're starting off with a pill and it seems like your estradiol levels are low, then they might add an injection or a patch or even a suppository. So there's lots of ways to kind of build your estradiol level. It just depends on what your doctor prescribes and what you respond best to. Some patients, not all patients respond well to the same medication. So that's another thing to consider. They may, mix it up for you based on how you're responding. The other big medication that I know a lot of patients hear about is the progesterone injection. So after a few weeks on the estradiol, the doctor will bring you in for what they call a mid-cycle scan. So the mid-cycle scan is what's used to check your lining, make sure it's thick and ready for transfer. Once we know that that thickness of the lining, of the endometrial lining, has grown and that you're ready, the doctor will then introduce your progesterone medication to the body. And so progesterone is a hormone that helps support the pregnancy in the uterine cavity. And that's a really important medication too. Low levels of progesterone can cause miscarriage. It can cause bleeding if the levels are low early on in the pregnancy. So it's really important to get a good number on board. Every doctor's threshold is different. Over 10 usually is what they like to see. Some are a lot more conservative and want it even higher. You can't take too much progesterone. So sometimes they may have different forms that you take all at once. They may have you do both the suppository and an injection. So with progesterone, the most commonly used form of the medication is the IM injection. So you're going to be getting what you see in your package of meds, a lot of needles, because you're going to be on progesterone through the first trimester of pregnancy, typically. So you'll get a lot of what we call these pink needles, and these are 18 gauge needles. So they're fairly large, and it's because the progesterone is oil-based. So because it's compounded in oil, whether it's sesame, olive oil, or ethyl oleate, it's a really thick substance. So we have to use a fairly large needle, which is not fun. So always make sure you're paying attention to the size of your needles. This needle is used to draw up the medication from a multi-dose vial again. So again, you're going to always alcohol the top of your vial before you draw up your medication, and then always use a brand new needle. So let's say the doctor prescribes you 2 mLs of progesterone. So I don't know if you can see on the vial, but you've got these little numbers, and you've got your rubber stopper, and you're going to measure to the 2 when you're measuring out from the vial. So usually what I have patients do is put a little bit of air in the syringe before you enter it into the vial. So when you pop this top, there is a rubber stopper, and that rubber stopper you're going to puncture with your needle. You're going to turn it upside down, and you're going to push that air in, and then you're going to take out your dose. Usually what I tell patients is go past your dose and then push back up to take the air out. And because it's oil-based, it's going to take a long time for the bubbles to go. It's slow. So just mess with it. No way is the wrong way, whatever you're comfortable with. Make sure you get your dose measured. And then you carefully recap your needle. You're going to lower so that you have a little bit of air once your dose is in the syringe, so that when you take this off, you're not missing your dose, you're not losing any medication in your syringe. Then you're going to switch out to your injecting needle. So the injecting needle is still the same length, but it's a lot thinner. And I'll show you what that looks like right now. It's usually a 25 gauge. It's a lot thinner, but it has to be long because it has to go into the muscle of the buttocks, of your glute. So once your dose is here, you've got your needle on, you're going to take that little bit of air out from the top, and you don't want it squirting out of the top of the syringe of the needle because you don't want to lose your dose. So you're going to take the air out. You're going to make sure that you have no large air bubbles, and then this is ready for injection. Again, this is upper outer quadrant of your buttocks. Not every patient has to be on this medication. I know it looks really scary. It's always getting past the first hump of the first injection. Once you kind of get a feel for what it feels like, it's usually not too bad. You do kind of get used to it. So when you're injecting this medication, the needle does need to go all the way in. So again, you're going to pinch the skin. Needle is injected all the way in. You're going to what they call aspirate, which is pull back, and then you inject. You're pulling back so that you see an air bubble. If you pull back and you see a spot of blood, that means you're in the blood vessel. So you want to take out. Technically, you're supposed to use a new needle and then pick another spot, inject, and do the same technique. Aspirate and then inject. The likelihood of you hitting a blood vessel is very slim. It never happens, knock on wood. It's just how nurses are taught to aspirate, to make sure that it's going into the muscle and not your blood vessel. So I know a lot of you are saying, yikes, and this is scary, and it's a lot, but you'll have a lot of support. I would ask lots of questions. You'll have lots of tutorial videos. I always guide my patients to view tutorial videos. Some of the pharmacies have really good ones online, and I always tell them, even if you want to do a play along as you do the first injection, just to make sure, because there's so many steps, there's so many things you're thinking about, you know, am I in the right spot? Am I using the right needle? Am I holding it right? And so watching the video as you're giving your first injection is always helpful, because you're not having to think so much about the different steps. And you can kind of, whether you're doing them yourself, which is possible, or if you're having your partner or a friend help you with the injection. Again, it's not always that you'll need to do the progesterone injection. Some doctors will use vaginal suppositories. There's also oral pills for the progesterone, but the progesterone is very important for your transfer cycle. So, as well as the estradiol, but the progesterone more so. It's timed, it's given so many days prior to your transfer, so you want to make sure that you're not missing your dose. If you ever feel like you missed a dose or you didn't give it on time, always make sure to contact your case manager or your doctor or whoever your contact is at the IVF clinic. You always want to make sure that they're in the know of whether you missed a dose or you're going to be late for giving a dose. That way they know they can manage it. The sooner they know, the easier they can manage as to what the next step should be, whether they need to double up a dose or if they need you to just hold off till the next day. So it's always doable. Side effects. So of course, the biggest question is, what are the side effects to these medications? Am I going to be irritable? Is it possible to have an allergic reaction? So these medications are hormone medications. So they're within the body that, you know, they're affected throughout your period. You feel them, they're natural hormones. So not typically do you have an allergic reaction to these medications, but you might have an irritation to the local injection site for these injections. The progesterone and estradiol injections, because you're giving them progesterone you're giving every day. So over time, you may build scar tissue. So you may have irritation at the site because it's not absorbing as well into the skin as it was at the beginning. And so there's a couple of tricks to the injections. What I like to tell patients is try a moist compress. So a washcloth, you're going to run it under hot water and you're going to massage the area. It's the moisture with the heat, and that will help with the oil to kind of disperse into the muscle a little bit better. It's not going to take the pain away completely or the soreness or the irritation, but it'll definitely help. Some of the other medications that you may be using aside from progesterone and estradiol are steroids. So a lot of times your doctor will have you on a steroid dose, whether it's a long-term so that you're taking it the entire cycle, which is maybe dexamethasone, or a short stint, maybe a Medrol dose pack. So the reason for the steroid medication, it's almost as though the embryo is a foreign object going into your uterine cavity. And so what we're wanting to do with the steroid is we're wanting to suppress the immune system so that you have a less response with the embryo going into the uterine cavity. So on the endometrial level, it's kind of helping sustain that embryo and help it to grow by the body, not rejecting it, thinking it's a foreign object, if that makes any sense. So some may be on a long stint of steroids, others may be on a long or short. It just depends on your doctor's protocol. Some patients may be on antibiotics. Not every patient. Usually that's for more of a surgery type. If you're going to have a hysteroscopy, they may put you on antibiotics. So not all patients will, but they may give you a Z-Pak. Some doctors are very conservative, so they want to rule out any possible infection during any type of procedure. So they may put you on a short antibiotic dose. Some patients may be on an anticoagulant. So that may be in the form of a daily aspirin dose. Or some doctors may just put you on an anticoagulant. What the aspirin does is that will help you with your blood flow to the uterine cavity. So some doctors just want to give that added assurance that the blood flow is flowing and you've got, a blood thinner in your system. And so sometimes they'll prescribe that. There may be additional medications prescribed outside of that. Most of the times for surrogates, I see if their thyroid levels are a little elevated or more than they prefer, they may put you on a dose of levothyroxine or synthroid. And sometimes, a lot of times with surrogates, they'll see, well, my thyroid level was normal. It was, below 5. So it's technically within range, but it's like 4.2. And so with that, then they may want to lower your dose a little. So infertility, doctors want to see your thyroid level closer to 2.5. And that's because they've seen with patients on a higher dose or a higher level of thyroid that they may have issues conceiving. So they want to give added assurance knowing that your thyroid level is lower. So some patients may be discouraged thinking, well, I have a normal thyroid, why am I on medication? It's in the fertility world, they want that level a little bit lower. So it's normal, it happens, and usually you take it throughout the pregnancy and then you're usually able to wean off. You may experience, so a lot of your side effects may be related to hormone levels. So what are we doing with your hormone levels? We're fluctuating them. We're starting you on medications. We're stopping you on medications. We're, mimicking the natural cycle of your body becoming pregnant. So with that, you're going to experience nausea, possibly headaches, possibly irritability. It's almost very period-like menstrual PMSing, which is awesome, and weight gain. Especially with your steroids. If the doctor has you on a dose of steroids, long-term, you may see some weight gain also. So all these things are normal and to be expected. If they become so bad as far as your headaches and you're having a headache every day and it's just not getting worse or it's turning into migraines, always talk to your doctor or your nurse coordinator. There may be ways that they can adjust your medications, or maybe it's the form of medication you're taking that they may be able to change. But always important, before you stop any medication, always consult your doctor or your nurse coordinator. Don't ever stop medications without your doctor or nurse having knowledge of that, because that could potentially cancel, stop your cycle, or postpone things. And of course, if you feel like you're ever having an allergic reaction to any of the medications, which is very rare, always reach out to them and give them the update as well. Okay. At the end of our handout that we have on here, there was a bunch of glossary terms that you'll hear most often when you're going through an IVF cycle. So as I had mentioned before, your estradiol and progesterone levels, those are super important. And you'll be hearing E2, which is estradiol, and P4, which is progesterone, spoke very often in the clinic. So that's what the clinical side refers to these labs and tests, because we manage them so often. So usually when you go in for your monitoring throughout your cycle, you'll often have an estradiol level drawn, and that's to make sure that it's increasing with the medications that you're taking. At the very beginning of your cycle, they're also going to check your progesterone level, P4, and that's to make sure that you have not ovulated or that you don't have any issues starting at the beginning of your cycle. And then, of course, when you're pregnant, with your transfer, they check your pregnancy test in combination with a progesterone level, because they want to make sure those progesterone levels are high, and that they don't need to add additional medications to sustain the pregnancy. FET obviously is frozen embryo transfer. I know you guys have heard that before. Mid-cycle scan is what we referred to earlier. So that is something halfway through after you've been on estradiol. They will bring you in for a lining check. And so labs will usually be drawn. At the beginning of your cycle, when you come in for what they call a baseline or stim start, that's to start the FET cycle. So you'll have labs drawn then. When you do come in for your mid-cycle, some doctors will base their findings solely on an ultrasound and won't require labs. Other doctors want to check your estradiol and progesterone to make sure at this point, with you being on the estradiol medications, that you've not ovulated or that your estradiol is high enough and you're responding to your medications. So every doctor has their own way of measuring things, whether they use labs at mid-cycle scan. Some do, some don't. And then post-transfer, obviously, the big test, which is usually 2 weeks later, is your pregnancy test. And most doctors will check that level the first time to confirm pregnancy. With a positive, they will repeat that 2 days later. And so if you look at the terms here, HCG, it's also referred to as BHCG or beta level. You'll hear nurses say HCG, BHCG, beta. They're all the same. And basically that's human chorionic gonadotropin. And that's the hormone in the body that detects, it's the pregnancy hormone. And so that's what we're checking when we do your blood draw. It's also detected in urine, in a urine pregnancy test. And so with that, as I said, they'll check that 2 weeks after. It's usually, every doctor is different. So it could be 10 days post-transfer. It could be 12 days post-transfer. Some will do a 10 and then 2 days later, which is 12 after transfer to check pregnancy. And so what they're looking at those levels, above 5 is considered positive, but they're more so looking at the level from the first test to the second test 2 days later to look at the pattern. They want to see it doubling. It should double every few days, and they're looking at that level to ensure an ongoing pregnancy. That's the best we can assess an ongoing pregnancy that early. Technically, when you do have your pregnancy test after transfer, you're about 4 weeks and so many days pregnant. So it's super early in the pregnancy for us to even be monitoring, which is amazing that we can do that. With a positive, the first time that they can perform an ultrasound would be 2 weeks following that. So it's a lot of waiting. The first ultrasound is at 6 weeks of pregnancy. So I know that's the hardest thing for a lot of surrogates. And so waiting for the pregnancy test, or you're waiting for, to take the pregnancy test after transfer, or you're waiting for transfer when you're on these meds. So it's a long process. Definitely, it can be a little more so like a waiting game. There's only bits and pieces of information you can get at a time as we move along. Going back to the terms, with the embryo transfer, there's day 5 embryos, and there's blastocysts, and there's embryo quality. All these things are discussed early with the intended parents. They would normally have this information as to what embryos they have and how many do they have and how are they graded. Every doctor's office, doctor's clinic, lab will grade a little differently as to how they assess the embryos. But a day 5 is usually grown out 5 days after the egg retrieval. Day 1 is considered the day after retrieval, and then they count on, and that's how they determine. So you might have already heard the term at day 5 embryo versus a day 6, and whether they're genetic tested. So also on here, you'll see PGTA and PGTM testing. PGTA is looking for any aneuploidy. It's looking for any abnormality in an embryo. And the PGTM, you may have an intended parent that had a specific genetic disorder that they were looking for and identifying to make sure that they're not passing on that to the embryo that they implant. They want to weed those out and pick a normal embryo. So that may be something you hear from your intended parents or your doctor as you guys start planning what embryos you're going to use for transfer. And then of course IVF, in vitro fertilization. And then we've added the terms for the procedures that you guys may or may not have. So HSG is a hysterosalpingogram. That's not as often seen with surrogates because we're looking at the tubes. The hysterosalpingogram is they use dye to flow from the uterus into the fallopian tubes to make sure that they're clear. That's usually more so for patients going through IUI procedures, or it may be a traditional surrogate and they want to check before moving forward with the cycle. Hysteroscopy would be something that would be required should it be needed after a sonohysterogram. So again, if you do your sonohysterogram and they find anything impeding in the uterine cavity, that may be the next step as a hysteroscopy. So don't be discouraged if you don't pass the SIS or the saline sonogram with flying colors. If they see something, it happens. It's more common than you think, and it's an easy fix. It just makes the process a little bit longer. And also an important thing, the mock cycle. So a lot of clinics will choose to do a mock cycle on their surrogates. This we see more so if the intended parent has a limited number of embryos and they really want to ensure that you as a surrogate are responding to the medications, and we're going to do a quick, practice run through the cycle to make sure that your uterine lining looks great and you're responding and there's no hiccups along the way, so that when you do start for the FET, the actual embryo transfer cycle, they already know what to expect or what dose you respond best to. Some surrogates can be discouraged by that, but I look at it as a positive because, one, you get a practice run on how to do these medications and what to expect. You know what the process is like and the timeline. So by the time you do your actual transfer, you're a lot less stressed. You know how to do the medications. So that weight's kind of lifted of, how am I going to do this? How are we going to do the first injection? What am I going to expect? And so you're a lot more relaxed, which means usually a lot less stressed, and the cycles go really well. So that is everything that I have on my notes. Sunshine and Casey, I don't know if you wanted to have me add anything, if I missed anything. I know it's a lot of information, so I definitely didn't want to give all of you ladies too much, but I also wanted to introduce the stuff to you guys to see what questions you guys have specifically, because I know everybody meets their own different challenges through this process. So Rachel's asking, how long does an IVF cycle last? So it depends on your intended parent. So if you're intended, most often, a lot of you will have intended parents who've already created their embryos. So they already have the embryos created, and then now we're just going through the process of the frozen embryo transfer. So the process itself from start to finish, at the start of your cycle to the time we do transfer, can be, depending on the protocol, can be anywhere from 3 to 4 weeks, so about a month process. And think of it because we want to start you on your estradiol, and it usually takes about 2 weeks to build that lining. And then they start progesterone. Once we know that your lining's built, it's thick enough, and we want to start your progesterone medication. And so your progesterone is usually about 5 to, well, depending on the doctor, it can be anywhere from 6 to 7 days before your transfer. So again, we're mimicking the natural process of the body. So we want to introduce the progesterone in a timely fashion. It's very time sensitive as to when you start your progesterone and when you can have your embryo transfer. So they calculate all of that for you, and then they kind of put it all out on the timeline for you.
You missed about how abstaining during the cycle. When do they typically advise you to start abstaining, and when do they let you get back to business?
So abstinence, typically in most of the clinics I've worked at, will start at the beginning of your FET cycle. So usually you'll come in at the start of your period. Some clinics, our clinic runs a pregnancy test, so we confirm that there's no pregnancy, and then usually from there, I know the husbands, partners don't like to hear that, ever, but unfortunately it's from there on. With positive pregnancy, that can last usually the first trimester, and that's only because in first trimester of pregnancy, intercourse, orgasms can lead to spotting, bleeding, and so we want to avoid anything that's going to cause a scare to anybody. So we do ask abstinence just to ensure that there's no issues with the implantation of the embryo. I saw the thumbs down from Sunshine. So the first trimester, yeah, usually the first trimester. So typically IVF clinics will monitor you as a surrogate in pregnancy until about 8 to 12 weeks, depending. Some doctors will discharge you and graduate you right away to your OB at 8 weeks. Others will want to see you through 12 weeks of pregnancy, which is usually the length that they'll keep you on medications. And that's because after 11 to 12 weeks, that's when your body should start producing its own progesterone and hormone levels. So it's safe to start weaning you off your injections and medications. And so that's usually how long you can expect to see your OB or your IVF doctor before OB. Any other questions?
Faith had a question. She was wondering if there's anything they can work on to possibly avoid any of the medications or reduce them.
As far as hormone level or hormone medications, so it depends on your doctor. So progesterone and estradiol will always be needed. It just depends on the form of medication that your doctor prefers to use. So that would be something you can discuss with your doctor, with your IVF doctor, to see how lenient, how flexible they are with the protocols. You may run into some doctors that are adamant about using this protocol for, all my surrogates, and this is, what we trust works. And so sometimes it's not negotiable, unfortunately. So Lily's asking, is there ever a procedure where your IVF doctor will monitor your progesterone levels? Yes. So FET cycles, your frozen embryo transfer cycle, they will check your progesterone levels from time to time. That's a great question. They'll check it at the beginning to make sure that it's not elevated. They're checking your levels at the beginning of the cycle to ensure that everything's suppressed. Before you start medications, I always say it's like a blank canvas. And they want everything off, everything suppressed and quiet before they start your medications. And then your progesterone's checked later on to make sure that you're taking enough medication. So progesterone and estradiol are typically used through first trimester. Correct. Some doctors may stop the estradiol sooner than progesterone, because once you're pregnant, progesterone is always the most important hormone because that's what will sustain that pregnancy. It helps support the pregnancy in the uterine cavity during that first trimester. And again, as I mentioned, once you get closer to 12 weeks of pregnancy, your body will start producing its own, where it's safest to stop that medication. And that's the big one. Yes, Katrina. Every day. So yes, the progesterone is given every day, depending on what form of, and unfortunately progesterone has to be given every day. There's no, yes, your poor butt. It's usually once a day. Usually in the evenings, again, some doctors are, time it just right to where they may have you give it in the morning versus the evening, but it's once a day. Estradiol can be every couple of days, or it could be every day depending on the form of medication you're using. If it's an oral pill, then yes, it's every day as well. As far as prenatal vitamins, some doctors are specific on which ones they prefer you to take. I say at this point, and most doctors agree, as long as you're taking any form of prenatal, start taking them now. It definitely won't hurt. We see a lot of patients with low levels of vitamin D. And that's just because we're all told to put sunscreen on and stay out of the sun. And so it's very common to have low vitamin D levels. So that's another level they check during your initial screening. So be prepared that you may also be asked to take a vitamin D supplement. But for now, any over-the-counter prenatal vitamin, some like gummies, some are okay with the pills, whatever form you prefer to take. Yes, and Sunshine, you're right. You had the injection, the estradiol injection. It was every couple of days, but with the pills, you took them every day. So depending on the form of medication you're taking, it just depends. And Cheyenne, that's my daughter's name, was told to start taking prenatal vitamin D and iron now to ensure. That's perfect. I think that's a great idea. Taking them now will definitely not help. And do you have to take anything for liver support? No, Rachel, no need to take anything. As long as you're taking a daily vitamin, prenatal vitamin, that's sufficient. And Lily, with the vitamin D, could we be tanning in a healthy environment? I don't know. It would depend on your doctor. You can up your vitamin D level. You can definitely take a daily supplement. It also helps to support your immune system. And this time in our lives right now, supporting our immune system is super helpful all around. So yeah, absolutely. If you felt comfortable with taking it, it's definitely not going to hurt. Any other questions?
Hi, Beth. Confidence levels improved with how confident you feel about going through this process, and it looks like they have gone up. If you haven't answered, go ahead. We don't have any ones anymore. That's really nice. I know I started at a 1. And
also, very important to mention, don't feel like you're needing to be a pro after all of this. It's the first time maybe you're being exposed to this information, so you'll hear it more. Just don't feel like you need to know all of this stuff by the end of this webinar.
yeah, it gets easier, but it is scary at first. Looks like most of you are going to be doing your own injections too. Good for you. I couldn't do it.
Yeah.
My husband did my injections and he was so scared. He had to take like 3 shots before he gave me my first injection. So he was a little swervy, which made me a little bit more nervous. But then he was just like, oh, whatever. Yeah, he's just got it. He's so good at it.
Yeah. I had done my second journey, and I did it myself, and I was not super excited about it, but I did it. And, you know, I didn't think I could. I didn't think I was going to be comfortable enough or flexible enough to turn over, and I did. So for you ladies who have to do it yourself, honestly, it isn't as bad as you think it's going to be. There is more confidence when you do it, you know?
Absolutely.
And then you're just like more proud of how awesome you are because you can do anything.
Exactly. Thank you, Natalie, for taking the time to educate us, our girls, and we really appreciate your time, and it's so valued.
Honestly, having gone through 3 cycles, I never knew why I took the steroids. I just took them because they were on the list and on the calendar. And I just, you know, some people are really type A and they need to know why and what is this doing and why am I taking this? And I'm just like, oh, okay, well, take what they tell me. I feel so much more educated now.
Yes, yes.
I know Lorena had a quick question about the COVID testing and the immune, getting the vaccine and all of those details. So there has been conversation about that as well. COVID testing is being done in most IVF clinics now before procedures to make sure that you're testing negative. That's a big topic right now. And now that the vaccines are becoming more available, always discuss that with your provider. It has been approved. The board of OB/GYN they have approved it being given to pregnant women. But again, that's a little controversial. So definitely make sure you're talking to your intended parents and you're talking to your IVF doctor on what their recommendations are.
And then Madison wanted to know who decides the doctor and pharmacy and what type of oil for the progesterone injections. The doctor is whoever your intended parents. They have an IVF doctor selected already that has created their embryos, so they'll make that decision. I don't know about pharmacy, Natalie.
So most doctors will use, again, like I mentioned, because these are compounded medications, they're not sent to your local CVS or Rite Aid. These are usually sent to, fertility pharmacies. So you'll hear MDR, you'll hear Freedom Fertility, you'll hear Alto. And so it just depends, but they all can ship all over. So you'll get all medications will get shipped to you directly, or in certain instances, depending on your location to the IVF clinic, they'll send the medications to the clinic and then you'll pick them up at one of your appointments.
And as far as the type of oil that they choose for the progesterone and oil, I think that would probably be determined by the doctor and the pharmacy, right? So if there's something that you're sensitive to, like I know sometimes some people are sensitive to the sesame oil, and so they'll, let your clinic know, and then they'll change it to a different oil.
And there's no way
they're
of
having itching or something.
Yeah, there's no way of knowing whether you're going to have a reaction to it until you start injecting. The reason why they automatically will prescribe sesame oil is because it's a little less expensive than the foliate. It's a little more, but they can definitely change the prescription if needed. If you're having a reaction, it's definitely not a problem.
And a lot of people have husbands excited to stab them with needles. That's funny.
Very common to hear that. I don't know why. We just have them get saline injections every so often too, so they can feel the pain.
Yeah, let's give them shots. How many times will you travel out of state for IVF? I think for the most part, it's medical screening and transfer, right?
Yeah. So medical screening for sure, transfer for sure. And then we talked about outside monitoring, and what that means is finding a clinic or center nearest you locally where you can have your monitoring done there. If that's possible, then you'll be able to do some of that testing and ultrasound work closer to home.
Okay, I just want to make sure we didn't miss any more of these questions.
Oh, tell your daughter that mommy has the same name as my daughter. Cheyenne is my daughter's name.
It's a beautiful name too. What's your daughter's name, Cheyenne? Medical screening is actually way before transfer. So the medical screening will happen, and then it'll take 2 weeks to get the results from the screening, because they'll wait for your lab results to come in. Like when they look at your uterus right away, they'll tell you if that looks good, but then they have to wait for your lab results. And then for your husband, Laura, your husband will have to get his labs done too. And I think sometimes what slows people down is their husbands will drag their feet on going to Quest to get their labs done, so that can slow down the process. So make sure as soon as you get that lab slip, you send him to the lab right away, because it sucks. You know how anxiety inducing it is when you're just like, I want to know if I cleared, and you're waiting on this guy. So send him to the lab right away if you can. And then once you have medical clearance, then they'll wait for your period to start, and then they'll give you your calendar. Right? Is that right, Natalie?
Yeah, so usually you won't have a transfer cycle until your medical screening is good.
My pants are unbuttoned.
Well, just the beginning, why do husbands? So husbands need to be screened as well, because technically you're sexually intimate partners. So you have to screen your partner to ensure that everyone is negative. So I know they hate doing that, but yeah, again, make sure they go as soon as possible. So it usually is what delays things, because the sooner you have medical clearance, then the sooner we can start planning for your cycle, for your transfer cycle.
Something I also stressed. Oh, sorry, go on.
Oh, go ahead. I was just
No,
going to say the husbands are going to be screened for infectious diseases as well as tobacco and drugs. So I know it's one of those things that you want to be forthcoming about. If your husband smokes marijuana from time to time, let your agency know that right away, because it's going to come up in the medical screening, and we don't want those things to be surprises. Those things need to be disclosed. It's just happened.
It's fine. It's just give us the update.
Nobody likes surprises. No surprises.
Yeah. It won't, it's not a, you know, it's not a no deal. It's just, we need to know that info.
And something I was just going to share also with the husbands, when they go in, this is something that I've experienced dealing and having the surrogates with their spouses. Make sure that when they go in with that lab slip, the husbands aren't giving their insurance card, because the LabCorp or Quest Diagnostics is in the, I guess, the normalness of asking for your insurance card. But you shouldn't be supplying an insurance card. On the lab slip, it will say bill the IVF center. And so it's really important that you tell your husbands, don't give your insurance card. It will say on there specifically how you're supposed to bill, and so that the LabCorp or Quest Diagnostics can bill the IVF center for those labs, and then you're not figuring out how to be reimbursed after the fact for those items.
When you get that lab slip, look at it right away, because the clinic that I was with, their lab slip they gave me specifically said, do not bill the IVF doctor. So I know Casey has the best face. I had to, I showed up with the lab slip for my husband, and it said, don't bill the doctor. And my agency, which is not an agency that I refer anyone to, did not prepare for that. So for me, I you know, fortunately had enough credit that, because these labs are like $750. So I paid for the labs on my credit card. Both times they did this agency, but I'm like, it's fine. I need the points. I need the Southwest points anyway. So I paid for it on my card and got reimbursed. I get reimbursed for it. But if you don't have the means to do that, you know, make sure that you look on that and ask your case manager who's paying for this. Have you contacted the lab? Is there a card on file? Because they should do that, but they might not. And it would really suck for him to go in, and then they're like, okay, pay for this. And he's like, $750, you know.
Or worse, they charge the insurance, and then insurance kicks it back, and then you're dealing with that too. So just make sure you're not giving an insurance, your insurance card. It can add an extra layer. You are going to get insurance that's surrogacy friendly at some point, but at the very beginning phase of this, with all of the IVF, you won't be using your insurance. So there shouldn't be at any point that you're putting that card on file.
He won't be going to the military. He won't be going to the military clinic. He'll go to a Quest or a LabCorp or something. Or maybe even going to a medical screening with you and getting his labs. That's possible too, that they can get them, that if they can travel with you to the clinic and get their labs drawn the same day that you do, that's also an option sometimes.
Really great questions, ladies.
We're going to do a whole other webinar on insurance. That's a whole, that's a whole thing. Yeah, awesome. You won't go to the Army hospital, Faith, not for surrogacy. You get to go somewhere on your private insurance. I don't know if that's better or worse. I don't know how military insurance and hospitals are. If they're any good. Maybe it depends on where your region is. I don't know, but you get to go somewhere nice. Okay. Anything else that we missed? Yeah, if he vapes nicotine, just make sure that they know before he does his labs that's going to show up. Adriana asked, how soon after giving birth can you start the process?
So after birth, you go for your 6 weeks postpartum if it's vaginal delivery, or 8 weeks postpartum for C-section. Usually most doctors would need a clearance from your OB stating that you're okay to proceed. If it's your own and you're breastfeeding, they also want you to be weaning off breastfeeding, so that when you do start medications, you can't be breastfeeding. So it really depends, at least a few months, but they want you to have that clearance from your OB doctor to state that you're okay to proceed.
It's usually 6 months after a vaginal delivery and a year after a C-section, right? That they want you to wait. No,
That's what I typically see.
Yeah, some people are like boom, 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 back to back. I don't think I could handle that. My body says no. You need to wait at least a year.
Yeah.
6 seconds. Okay, I think did we miss? Is there any other questions you guys want us to answer before we go? And then I was going to ask you guys. I think we were going to plan to do another webinar coming up soon. I was just talking with my financial advisor because when I first became a surrogate, I had this money and I was like, what do I do with it? I don't want to blow it. I want to invest it or do something, and I didn't know what to do. So I was talking to him about maybe doing something to help make a plan for your compensation and what you're going to do, because it's good to have a plan. Otherwise, you know, it's really easy to spend that extra money. It's so easy. You're like, wait, where did that $40,000 go? In my belly, the DoorDash. That's where. So that was the one that I really wanted to do, but I didn't get a lot of interest on that one in the polls from the Facebook group. And then the other thing we were going to talk about was the timeline for the screening process before we get up to Natalie's medical screening and all that good stuff. Do you guys have anything else? Any other topics you want us to cover? And we can totally let you go, Natalie. Thank you for staying with us for all this time. I know you probably have a commute to go home to, but you're welcome to stay.
We really, really are so excited that we had the opportunity to have you.
We're so grateful for you.
No problem. Thank you, ladies.
Oh, there was one person that asked earlier on, and I scrolled past it. She was asking, is there any way to get your shots done at a clinic? Or who asked that question? Somebody asked that question a long time ago. We got a busy chat. I'm glad I kept this open. Wanted to know if there's any way. And unfortunately, I think most people have to do their injections at home unless you live in Orange County or LA. Then you could get your IPs to hire Natalie to come do your injections for you with moonlight injections. Otherwise, I think most of us are on our own.
And I don't just do in person. There's also option for video chat during that first injection too, that I'm happy to do. So sometimes it's just having peace of mind with somebody there walking through it with you, just to make sure you're doing everything correctly. So that's also an option.
I mean, you have a big old butt cheek and you're like, I got to put it in here. Where's the right spot?
Yep.
Like, that's what I always want. Like, can you just draw a circle and I'll just aim in the circle?
Yeah.
And I just walk around with purple circles on my butt.
Well, thank you. And my email's at the top of that handout. So if anybody needs a question answered, please feel free to email me. It's an easy, no question's a dumb question. So feel free to reach out.
Yay. Thank you, guys.
You guys, when you go in for your screening and stuff, when you see your IVF nurse, you can ask them to draw a circle on your butt and they will.
And it's not a weird thing. No.
All right. Well, you guys have a good night. Thank you so much for coming and joining us for this webinar. I hope it was helpful. And we'll let you know what we've got planned next for you.
Awesome. Yay. Thank you, ladies. Have a wonderful night. Thanks for joining.
We'll see you in the Facebook group.
Yes. Bye.
Bye.